My name is Lauren Dyroff, and this presentation was created in collaboration with Dr. Pavlina Kemp. Today we will be talking about health disparities and their effects on pediatric eye care. Starting with some basics, what does a pediatric ophthalmologist treat? Pediatric ophthalmologists treat a wide range of diseases affecting everything from the eyelid to the optic nerve, many of which can significantly impact visual development. The prevalence of the most common visually significant childhood ocular conditions are as follows. Refractive error, including myopia, hyperopia, and astigmatism, affect anywhere from 1 to 11% of patients, while amblyopia and strabismus affect about 3 and 7% of patients respectively. Other less common but significantly vision-threatening conditions include retinopathy of prematurity, congenital cataracts, glaucoma, retinoblastoma, uveitis, and cerebral visual impairment, including traumatic brain injury. As a brief review, amblyopia is the unilateral or less often bilateral reduction of best-corrected visual acuity that usually occurs in the setting of an otherwise normal eye. The visual system does not develop appropriately due to abnormal visual input. Common causes include strabismus, difference in refractive error between the eyes, a droopy eyelid blocking vision, and cataract or other media opacity. Strabismus is a common condition where the eyes are not aligned properly. One eye may look straight ahead while the other turns in, out, up, or down, and the misalignment can shift from one eye to the other. So, why does this all matter? These diseases can impose significant cost on patients and their families. Direct costs of these diseases include doctor visits and the associated time off from work or out of school, medical vision aids and assistive devices, as well as special education and assistance programs. In 2012, the estimated economic burden of pediatric eye disorders in the United States was about $5.9 billion per year, and the estimated financial burden of lost pediatric well-being due to vision impairment and blindness was about $4.1 billion per year. Indirect costs are also important to consider. Untreated, these disorders can lead to long-term consequences for productivity and quality of life as adults. First is the interpersonal and professional impact. Olitsky et al. Evaluated perceived personality traits important in social interactions and employment capability. Photographs of strabismic faces were graded more negatively on traits including communication skills, intelligence, attentiveness, competency, emotional stability, leadership abilities, and organizational skills compared to orthotropic faces. Untreated or insufficiently treated amblyopia may limit career choices in fields requiring specific visual acuity or binocularity, such as military, law enforcement, aviation, and surgery. There are also psychosocial impacts. In one retrospective survey of adults and teenagers who underwent surgery for strabismus, more than 80% of patients reported embarrassment, trouble making eye contact, and low self-esteem secondary to their strabismus. There are a number of barriers that can affect access to care. Several studies have shown significant disparities in diagnosis and treatment of strabismus and amblyopia in less affluent communities. U.S. Census data from 2018 suggests that 1 in 6 children lives in poverty, defined as an annual income of less than $25,701 for a family of 4. One study showed lower rates of follow-up after initial screening, as well as lower rates of diagnosis of strabismus and amblyopia in families with lower net income, suggesting both underutilization and underdiagnosis in these families. The burden of time off from work, lack of reliable transportation, and relative burden of copay and deductible, and poor understanding of the importance of these diagnoses likely contribute to this dynamic. The geographic distribution of providers further limits access to pediatric eye care. The average distance to adult general ophthalmology nationwide is about 5.6 miles, compared to an average of 28.5 miles for pediatric ophthalmology. So the question is, how are we doing in caring for these patients? Healthy People is a national initiative program running through the Office of Disease Prevention and Health Promotion that provides science-based 10-year national objectives for improving the health of all Americans. Healthy People 2020 identified 2 objectives for improving pediatric eye care in the United States. Goal number 1 was to increase the proportion of preschool children aged 5 years and younger who received vision screening. In the upcoming graphs, the dotted red line represents the goal of screening 44% or more of children. Geographically, there was no difference between metropolitan and non-metropolitan patients, both reaching the 44% goal. Across racial and ethnic backgrounds, all groups reached the 44% goal, and there was no statistically significant difference between the groups. Between public, private, and uninsured groups, there was no statistically significant difference, but, importantly, uninsured patients had much lower average rates of screening, falling well below the 44% goal. In addition to assessing screening rates, it's also important to look at who is still losing vision. Goal number 2 of Healthy People 2020 was to reduce blindness and vision impairment in children and adolescents aged 17 years and younger. In the upcoming graphs, the red line now represents the goal of having fewer than 25 patients out of 1,000 reporting visual impairment. Family income data show patients with lower income consistently reporting the highest rates of visual impairment, and unfortunately, over the last 10 years, there has been a trend towards higher rate of visual impairment, especially in patients closest to the poverty threshold. In addition, patients who are uninsured or have public insurances consistently report higher rates of visual impairment as compared to those with private insurance. Certain racial and ethnic groups are also more heavily impacted by visual impairment, with Black and African American patients reporting the highest rates of visual impairment, followed by Hispanic and Latino patients. Lastly, family structure also has an impact. Single-parent homes consistently report higher rates of visual impairment as compared to two-parent homes. In addition to biology, genetics, and previously discussed barriers to care, there are numerous human, behavioral, and systemic factors that drive health decisions and affect their outcomes. These include the burden of multiple appointments and time off from work, the relative burden of copay and deductible, individual behaviors, distance to care, availability of transportation, implicit bias, family structure and dynamics, literacy levels and education, poor understanding of the need for follow-up, health insurance status, external stresses, and legislative policies, to name a few. Regular screening in the primary care setting starting at an early age is important, as many eye conditions are asymptomatic and benefit from early treatment. Red reflex testing, also known as the Bruckner test, should be done starting at birth. Patients should be referred to ophthalmology for any opacities, diminished reflex, white or yellow reflex, or asymmetry. You can also see the leukocoria module for more on this. Once old enough, critical line screening can also be done by including one eye with an adhesive patch and asking a child to read the critical line appropriate for his or her age. Patients should be referred if the child is unable to read a majority of letters or shapes on the appropriate critical line, which, according to AAO and APOS, are as follows: 20/50 or better in each eye at 3 years, 20/40 at 4 years, and 20/30 or better at 5 years or older. So what further steps can be taken to mitigate health disparities in pediatric ophthalmologic care? First, we can work to address accessibility to follow-up care for vulnerable populations by co-locating pediatric vision care services with public benefit programs and primary care offices, as well as by establishing strong connections between eye care providers and screening programs. In addition, we can increase awareness of health disparities and the cost of health deficits that may result from visual impairment. This can be done by supporting recommendations for mandatory preschool vision screening and improving parental education programs regarding the importance of vision screening and follow-up care. Thank you for your time and attention today. I hope that you learned something about health disparities and pediatric ophthalmology.